Hello dear friends, welcome to Pharmagrid. In our last sessions, we have discussed about two pharmacokinetic parameters, that is drug absorption and drug distribution. Today we are going to learn about drug metabolism, which is also known as biotransformation. Okay, so this biotransformation or metabolism means chemical alteration of the drug in the body. It is needed to render non-polar compounds polar, or else we can say that the purpose of metabolism is to convert lipid-soluble compounds to lipid-insoluble or water-soluble compounds so that they are not reabsorbed in the renal tubules and are excreted. Biotransformation is mainly for this lipophilic or lipid-loving drugs. Most hydrophilic drugs, which means polar drugs, for example streptomycin, neostigmine, are little biotransformed and are largely excreted unchanged. The primary site for drug metabolism is liver, others are kidney, intestine, lungs and plasma. In general, we can say that drug metabolism begins with a lipophilic drug or substrate and converts it to a more hydrophilic metabolite to facilitate its elimination. Consequences of drug metabolism. As we have already discussed, the purpose of metabolism is to convert non-polar compounds to polar water-soluble compounds. So in the process of converting a drug to a metabolite, the pharmacological activity of the drug may be changed. Metabolites can be broadly classified as either inactive or active metabolites. Okay, so as a result of this metabolism, active drug can be either converted to an active metabolite or an inactive metabolite, or inactive drug, which is known as a prodrug, can be converted to an active metabolite. So all the active metabolites can go to the site of action. Biotransformation of drugs may lead to the following. First one is inactivation. Inactivation means active drug on metabolism produce inactive metabolites. So the inactive metabolites of drugs are devoid of pharmacological activity that was characteristic of the drug or toxicant. This metabolic change may be considered an inactivation or detoxification. Example, ibuprofen, paracetamol, lidocaine, chloramphenicol, propranolol and its active metabolite 4-hydroxypropranolol. Here, the metabolite produced is inactive. Okay, so it cannot enter into the site of action. It can only enter into the kidney and undergo elimination or excretion. Examples of metabolism to inactive metabolites. So the first one is ester hydrolysis of the local anesthetic procaine to produce two inactive metabolites. Okay, so the hydrolysis of procaine to para-aminobenzoic acid and diethyl ethanolamine results in a loss of anesthetic activity, which means they have produced an inactive metabolite. So inactive metabolites cannot enter into the site of action and cannot produce its mechanism of action. They will directly enter into the kidney and undergo elimination. Next example is glucuronidation of acetaminophen to an inactive metabolite. That is, acetaminophen is glucuronidated on its phenolic hydroxyl group to an inactive metabolite, which is acetaminophen O glucuronide, that is rapidly eliminated. Next one is active metabolite from an active drug. Many drugs have been found to be partially converted to one or more active metabolite. The effects observed are the sum total of that due to the parent drug and its active metabolites. Active metabolites of drugs have pharmacological activity which can either be similar to the desired pharmacological activity or a new activity that is absent from the parent drug. So metabolites with a similar pharmacological activity retain the desired biological activity that is inherent in the parent compound. Examples of metabolism to metabolites with similar pharmacological activity. So the first example include codeine, which is a mild analgesic, is metabolized to morphine. Morphine is a potent analgesic. Okay, so codeine is a mild analgesic. On metabolism, it gets converted to an active metabolite, that is morphine, which is a more potent analgesic. Second example is imipramine, which is a tricyclic antidepressant, is metabolized to the active antidepressant, which is desipramine. Here you can see a list of active drugs and their active metabolites. Chloral hydrate, its active metabolite is trichloroethanol, and morphine, active metabolite is morphine 6-glucuronide. Cefotaxime, active metabolite is desacetyl cefotaxime, and alloxanthine is the active metabolite of allopurinol. Procainamide, its active metabolite is N-acetyl procainamide, and primidone has got two active metabolites which include phenobarbital and phenylethyl Then diazepam also has two active metabolites which include desmethyl diazepam and oxazepam. Digitoxin active metabolite is digoxin, and imipramine, its active metabolite is desipramine, and amitriptyline on metabolism get converted to its active metabolite nortriptyline. Codeine, its active metabolite is morphine, and active metabolite of spironolactone is cantrinone, and active metabolite of losartan is E3174. Next is the activation of an inactive drug. Few drugs are inactive as such and need conversion in the body to one or more active metabolites. Such a drug is called a prodrug. The prodrug may offer advantages over the active form in being more stable, having better bioavailability or other desirable pharmacokinetic properties, or less side effects and toxicity. Some prodrugs are activated selectively at the site of action. So in a nutshell, we can say that the parent compound devoid of pharmacological activity before metabolism is called a prodrug. And prodrug has got a lot of advantages over the active form, which include more stability, then better bioavailability, less side effects and a toxicity. In the case that the metabolite has the desired pharmacological activity, although the parent is inactive, the metabolism is called a bioactivation. Here you can see the examples of metabolism of an inactive prodrug to the desired pharmacological activity. So the first one is ester hydrolysis of the prodrug enalapril to the active enalaprilat. So enalapril, which is an ACE inhibitor, on metabolism get converted to enalaprilat. Enalaprilat is an active metabolite of enalapril. Second example is oxidation of the ketone on the prodrug nabimetone to the active non-steroidal anti-inflammatory carboxylic acid. Okay, so this enalapril and nabimetone are prodrugs, which means they are inactive, and on metabolism they will get converted to active metabolites in order to produce the desired pharmacological activity. Here you can see a list of prodrugs and their active forms. Levodopa, its active metabolite is dopamine, and enalapril, its active form is enalaprilat. Then alpha-methyl dopa, its active form is alpha-methyl norepinephrine. Then the active form of dipivefrin is epinephrine or adrenaline. Then sulindac, which is a prodrug, its active form is sulfide metabolite. Then proguanil, its active form is cycloguanil. Then prednisone, its active form is prednisolone. Then the active form of becamicillin is ampicillin, which is a beta-lactam antibiotic. Then sulfasalazine, its active form is 5-aminosalicylic acid. Cyclophosphamide, which is a prodrug, it has got three active forms which include aldophosphamide, phosphoramide mustard and acrolein. Then fluorouracil, its active form is fluorouridine monophosphate. Mercaptopurine, its active form is methyl mercaptopurine ribonucleotide. And acyclovir, which is a prodrug, its active form is acyclovir triphosphate. Next one is bioactivation of a drug can also result in a toxic metabolite. The parent activated is called a protoxicant. Here you can see the examples of metabolism of active drugs to toxic metabolites. So the first example is halothane. Halothane is a general anesthetic, is metabolized to a reactive metabolite associated with a hepatotoxicity. Next example is acetaminophen. We know that acetaminophen is an antipyretic. It is metabolized to the reactive metabolite N-acetyl parabenzoquinonamine. Okay, NAPQI. It is associated with a hepatotoxicity. Next, we are going to learn about the classification of biotransformation. So this biotransformation can be classified into two types, that is phase 1 reactions and phase 2 reactions. Phase 1 reactions are also known as non-synthetic or functionalization reactions, whereas phase 2 reactions are also known as synthetic or conjugation reactions. So the first one is phase 1. Here, convert the parent drug to a more polar metabolite by introducing or exposing a functional group. Okay, so functional group in the sense chemically reactive groups such as OH, NH3, SH2, that is the thiol group. So here a functional group is generated or exposed and the metabolites produced may be active or inactive. Many phase 1 metabolites are substrates for phase 2 reactions. Oxidation is the most common phase 1 reaction. Okay, so this phase 1 reaction is also known as non-synthetic or functionalization reaction. Here we are converting a parent drug to a more polar metabolite by introducing or exposing a functional group. Okay, and the metabolites produced here may be active or inactive. So the different phase 1 reactions include oxidation, reduction, hydrolysis, cyclization and decyclization. So the next reaction is phase 2. It is also known as synthetic or conjugation reaction. Here, coupling between drug and an endogenous hydrophilic substrate such as glucuronic acid to create more polar conjugates. Thus, conjugation enhances drug hydrophilicity. All conjugated products are pharmacologically inactive except morphine glucuronide, which is more active than morphine. Okay, so the phase 2 reactions means here we are combining the drug with an endogenous hydrophilic substrates such as glucuronic acid and thereby creating more polar conjugates. Okay, so all conjugated products formed as a result of phase 2 reactions are pharmacologically inactive. But in the phase 1, we have seen that metabolites produced may be active or inactive. But in phase 2, the metabolites produced will be inactive. Okay, so the exception is morphine glucuronide, which is more active than morphine. Phase 2 reactions include glucuronide conjugation, glycine conjugation, glutathione conjugation, sulfate conjugation, methylation and acetylation. First, we will discuss about phase 1 reactions, also known as non-synthetic or functionalization reaction. So among this phase 1 reaction, the most important one is oxidation. This reaction involves addition of oxygen or negatively charged radical or removal of hydrogen or positively charged radical. Okay, so this oxidation means addition of oxygen or removal of hydrogen. Oxidations are the most important drug metabolizing reactions. Various oxidation reactions are hydroxylation, oxygenation at carbon, nitrogen or sulfur atoms, nitrogen or oxygen dealkylation, oxidative deamination, etc. In many cases, the initial insertion of oxygen atom into the drug molecule produces short-lived, highly reactive quinone or epoxide or superoxide intermediates which then convert to more stable compounds. Oxidative reactions are mostly carried out by a group of monooxygenases in the liver, which in the final step involve a cytochrome P450 hemoprotein, NADPH, cytochrome P450 reductase and molecular oxygen. So oxidation is nothing but it is the addition of oxygen or removal of hydrogen. Most of the oxidation reactions are carried out by microsomal enzymes, which include cytochrome P450, which is the most important one, and others include FMO, that is flavin containing monooxygenases, then epoxide hydrolase, etc. Cytochrome P450. We know that the cytochrome P450 is a superfamily of mixed function oxidases that are responsible for the majority of oxidation reactions. This reduced isoenzyme gives a special peak of maximum light absorption with pink color at 450 nanometer when treated with a carbon monoxide. Hence, it got the name as cytochrome P450. And this enzyme is classified as a microsomal enzyme and in the cell it is bound to the endoplasmic reticulum. Cytochrome P450 is found in very high concentrations in the liver and to a lesser extent in the intestinal mucosa, lungs and kidneys. The cytochrome P450 is dependent on the porphyrin prosthetic group, commonly called the heme group, and NADPH to metabolize a wide array of substrates to numerous metabolites. There are several isoforms of cytochrome P450 responsible for drug metabolism, which gives wide substrate specificity to the family of cytochrome P450 enzymes. Each isoform has different substrate specificities based on the size and amino acid composition of the cytochrome P450 active site. The nomenclature for the cytochrome P450 enzymes is based on amino acid homology and divides the cytochrome P450s into families designated by an Arabic number, then subfamilies designated by a letter, and individual genes designated by an Arabic number preceded by CYP. Let's take an example of one cytochrome P450 enzyme, that is CYP3A4. Okay, so here the family number is 3 and the subfamily is A and the individual gene is 4. The cytochrome P450 families most responsible for drug metabolism include CYP1, CYP2, CYP3 and CYP4 with subfamilies CYP2C, CYP2D and CYP3A metabolize most drugs. CYP families CYP7, CYP11, CYP17, CYP19, 21 and 27 contribute to steroid and bile acid synthesis and metabolism required for homeostasis. The cytochrome P450 isoenzymes important in man are CYP3A4 and CYP2D6. CYP3A4 is the most abundant form and involved in metabolism of more than half of clinically used drugs, and the next most common form is CYP2D6. Okay, so the CYP3A4 carry out biotransformation of largest number, that is nearly 50% of drugs. In addition to liver, these isoforms are expressed in intestine, responsible for first pass metabolism at this site, and kidney as well. Inhibition of this isoenzyme by erythromycin, clarithromycin, ketoconazole, itraconazole is responsible for the important drug interaction with terfenadine, estimazole and cisapride, which are its substrates. Next is CYP2D6. This is the next most important cytochrome P450 isoform which metabolizes nearly 20% of drugs including tricyclic antidepressants, selective serotonin reuptake inhibitors, many neuroleptics, antiarrhythmics, beta blockers and opiates. Inhibition of this enzyme by quinidine results in failure of conversion of codeine to morphine. As a result, analgesic effect of codeine will be lost. Human subjects can be grouped into extensive or poor metabolizers. The poor metabolizers have an altered CYP2D6 enzyme and exhibit low capacity to hydroxylate many drugs. Here you can see the examples for common oxidation reactions. Aliphatic hydroxylation, allylic hydroxylation, benzylic hydroxylation, aromatic hydroxylation, epoxidation, orthodealkylation. So all these reactions are carried out by cytochrome P450 enzyme. Continuing with the oxidation reactions, S-dealkylation, it is carried out by cytochrome P450 isoenzyme. Then sulfur oxidation carried out by cytochrome P450 or FMO. FMO means flavin monooxygenase enzyme. Then N-dealkylation by cytochrome P450. Then N-oxidation by FMO or cytochrome P450. Then deamination, for example, is amphetamine. It is carried out by cytochrome P450 or monoamine oxidase. Then dehalogenation, for example, halothane. It is carried out by cytochrome P450. Then alcohol oxidation, it is carried out by the enzyme alcohol dehydrogenase, and aldehyde oxidation, it is carried out by the enzyme aldehyde dehydrogenase. Okay, so ethanol on oxidation gives acetaldehyde, and this acetaldehyde on oxidation gives acetic acid. Okay, so the enzymes responsible for alcohol oxidation is alcohol dehydrogenase, and for aldehyde oxidation is aldehyde dehydrogenase. And in case of mercaptopurine oxidation, the enzyme involved is xanthine oxidase. So we have already discussed about cytochrome P450 isoenzyme, which is responsible for metabolizing most of the oxidation reactions. So here we will learn about more enzymes which are involved in oxidation reactions. So the first one is flavin containing monooxygenase or FMO. It is a family of microsomal phase 1 drug metabolizing enzymes responsible for the oxidation of nitrogen and sulfur containing soft nucleophile substrates with metabolites similar to cytochrome P450 metabolites. Next is alcohol dehydrogenase. It is a cytosolic enzyme that oxidizes alcohols into aldehydes from primary alcohols or ketones from secondary alcohols. Next one is aldehyde dehydrogenase. It is a general name for a group of enzymes expressed both in the mitochondria and the cytosol that is responsible for oxidizing an aldehyde to carboxylic acid. Next one is xanthine oxidase and xanthine dehydrogenase. The two forms of the same gene product that are responsible for the breakdown of endogenous purines. Xanthine oxidase is a cytosolic enzyme that contributes to the metabolism of purine anti-cancer drugs, for example 6-mercaptopurine and other xanthines including caffeine and theophylline. Okay, so this xanthine oxidase is responsible for the metabolism of purine or endogenous purines or the breakdown of endogenous purines. Next is monoamine and diamine oxidase. These are mitochondrial enzymes that metabolize amines to aldehydes through an oxidative deamination process. Monoamine oxidase is responsible for the metabolic inactivation of catecholamines in neurons and the hepatic inactivation of biogenic amines absorbed from the gastrointestinal tract. Okay, so the xanthine oxidase is responsible for the metabolism or breakdown of endogenous purines, whereas this monoamine oxidase is responsible for the metabolism of catecholamines. Okay, so the next phase 1 reaction is reduction reactions. It is less common than oxidation but are still phase 1 reactions that add or reveal a functional group to increase the water solubility of the molecule to facilitate elimination. This reaction is the converse of oxidation and involves cytochrome P450 enzymes working in the opposite direction. Alcohols, aldehydes, quinones are reduced. Drugs primarily reduced are chloral hydrate, chloramphenicol, halothane, warfarin. Common reduction reactions include the reduction of disulfide bonds, carbonyls and nitro or azo functional groups. So reduction reactions means it is the addition of hydrogen or removal of oxygen. It is the converse of oxidation and involves cytochrome P450 enzyme working in the opposite direction. Okay, so here we are going to learn about the three important reduction reactions. So the first one is a common reduction reaction is a reduction of disulfide bonds commonly found between cysteine residues in proteins. Other sulfhydryl containing molecules can form disulfides that may be reduced back to the free sulfhydryls, or disulfide containing drugs can be reduced like disulfiram. Second one is aldoketo reduction with the help of aldoketo reductases that reduce a carbonyl containing compound back to an alcohol in a process opposite the oxidation performed by the alcohol dehydrogenases. Next one is the reduction of aromatic nitro group and the azo group. It is performed by a class of enzymes generically called nitro reductases and azo reductases respectively to produce free aromatic amines. The liver contains these reductases both in the cytosol and the microsomal cellular fraction. Additionally, gut bacteria have significant reductase activity for both nitro and azo groups. So the three common reduction reactions include reduction of disulfide bonds, then alpha keto reduction with the help of alpha keto reductases. Next is the reduction of aromatic nitro group and the azo group with the help of nitro reductases and azo reductases respectively. Here we will see the examples for common reduction reactions. So the first one is reduction of disulfide bond, for example disulfiram. Then aldehyde and keto reduction, example is methadone. Next is nitro reduction, for example chloramphenicol, which is an antibiotic. Then azo reduction, an example is sulfasalazine. Okay, sulfasalazine. So sulfasalazine undergo azo reduction to form sulfapyridine and 5-amino salicylic acid. Next phase 1 reaction is hydrolysis. Hydrolysis reactions add water across a bond to produce a more water-soluble metabolite. It is the cleavage of drug molecule by taking up a molecule of water, that is ester plus water in the presence of esterases. It will form acid plus alcohol. Similarly, amides and polypeptides are hydrolyzed by amidases and peptidases. In addition, there are epoxide hydrolyses which detoxify epoxide metabolites of some drugs generated by cytochrome oxygenases, for example carbamazepine. Hydrolysis occurs in liver, intestines, plasma and other tissues. Examples are choline esters, procaine, lidocaine, procainamide, aspirin, carbamazepine epoxide, pethidine, oxytocin. So esters like procaine are hydrolyzed by esterases, whereas amides like procainamide and lignocaine hydrolyzed by amidase. Okay, so the three common hydrolysis reactions include ester hydrolysis, amide hydrolysis and epoxide hydrolysis. So the first one is ester hydrolysis. It is commonly performed by the ubiquitous esterase enzymes found throughout the body. There is a significant esterase activity in the plasma that is responsible for the hydrolysis of an ester into a more water-soluble alcohol and carboxylic acid. A lactone, like found in erythromycin, is a cyclic ester that can also be metabolized by esterase enzymes. Second one is amide hydrolysis. It is performed by amidase enzymes that are generally expressed in the liver. Analogous to the ester hydrolysis reaction, the products of amide hydrolysis are an amine and a carboxylic acid. A cyclic amide is called a lactam and is the key structural feature for the beta-lactam antibiotics or the lactam antibiotics. Next one is epoxide hydrolyse. It converts epoxides into diols, which can be targets for conjugation reactions to facilitate elimination of xenobiotics. There is both a microsomal and a cytosolic form of epoxide hydrolase. Okay, so the three common hydrolysis reactions include ester hydrolysis, which is performed by esterases, then amide hydrolysis, which is performed by amidase enzymes, then epoxide hydrolysis, which is performed by epoxide hydrolase enzyme. So the common hydrolysis reactions include, first one is ester hydrolysis, which is performed by esterase. So here you can take the example of procaine. Okay, procaine is an ester. It is hydrolyzed by esterase. Next one is amide hydrolysis, which is performed by amidase or peptidase. And here you can see the example of lidocaine or procainamide, which is hydrolyzed by amidase. Next one is epoxide hydrolysis, okay, which is performed by epoxide hydrolase. So this epoxide hydrolase, they will deactivate potentially toxic derivatives, that is the epoxide generated by the cytochrome P450s. For example, carbamazepine. Carbamazepine get converted to its epoxide form, that is carbamazine epoxide by cytochrome P450 isoenzyme, which is then deactivated by epoxide hydrolase. So the next two phase 1 reactions include cyclization and decyclization. Cyclization means this is the formation of a ring structure or the formation of a cyclic structure from a straight chain compound. For example, proguanyl. Then decyclization means the reverse or the opposite of cyclization. Okay, so this is the opening up of ring structure of the cyclic drug molecule. This is generally a minor pathway. For example, barbiturates, phenytoin. Okay, so we have completed phase 1 reactions. Now we are moving on to phase 2 reactions. Phase 2 reactions are also known as synthetic reactions or conjugation reactions. These involve conjugation of the drug or its phase 1 metabolite with an endogenous substrate, generally derived from carbohydrate or amino acid, to form a polar, highly ionized organic acid which is easily excreted in urine or bile. Conjugation reactions have high energy requirement. Okay, so these phase 2 reactions require an enzyme generally termed as transferase that transfers a high energy molecule called the cofactor or co-substrate to the xenobiotic. The transferred cofactor is usually large and very polar, forming inactive metabolites. Okay, so this is the feature of this phase 2 reaction, that is the metabolite formed will be inactive. Exception is morphine. There are exceptions like methylation that do not increase polarity but do generally form inactive metabolites. So we know that phase 2 metabolism is the conjugation of a drug or its phase 1 metabolite with an endogenous conjugating substrate, thereby forming polar highly ionized compound which will be excreted in urine or bile. So among these phase 2 reactions, the most common and the most important one is glucuronide conjugation. It is the most important synthetic reaction carried out by a group of UDP glucuronyl transferases, that is uridine diphosphate glucuronyl transferases. Compounds with a hydroxyl or carboxylic acid group are easily conjugated with glucuronic acid, which is derived from glucose. Examples are chloramphenicol, aspirin, paracetamol, lorazepam, morphine, metronidazole. Not only drugs but endogenous substrates like bilirubin, steroidal hormones and thyroxine utilize this pathway. Glucuronidation increases the molecular weight of a drug, which favors its excretion in bile. Drug glucuronides excreted in bile can be hydrolyzed by bacteria in the gut. The liberated drug is reabsorbed and undergoes the same fate. This enterohepatic cycling of the drugs prolongs its action. For example, phenolphthalein, oral contraceptives. So this glucuronide conjugation, the endogenous substrate involved is glucuronic acid and it is carried out by uridine diphosphate glucuronyl transferase. Then glucuronidation increases the molecular weight of a drug. We know that glucuronic acid is the endogenous substrate here. It is of large size. So the conjugate formed with the drug will also be large. Okay, so because of its large size, it cannot enter into blood. So what will happen? So this drug glucuronides get enter into the bile and excreted in the feces. Okay, excreted in the feces, which will be 10%. Then remaining there will be 90%. So what will happen to this 90% of this drug? It will be hydrolyzed by bacteria in the gut. So the drug liberated. Okay, so by hydrolysis, the drug and the glucuronic acid will get separated. The liberated drug is reabsorbed and undergoes the same fate. Okay, undergoes the same fate, which this process is known as enterohepatic cycling of the drug. So enterohepatic cycling means it is a to and fro motion from liver to intestine and intestine to liver. Okay, so due to this enterohepatic cycling, it will prolongs the duration of action. Okay, so enterohepatic circulation prolongs the duration of action of the drug. For example, phenolphthalein, oral contraceptives. Next phase 2 reaction is acetylation. It depends on the cofactor acetyl-Coenzyme and the enzyme N-acetyl transferase to add an acetyl group to primary amines, hydrazines, sulfonamides and occasionally amides. For example, sulfonamides, isoniazid, para-aminosalicylic acid, hydralazine, clonazepam, procainamide. Multiple genes control the N-acetyl transferases and rate of acetylation shows genetic polymorphism, especially for the slow and fast acetylators. So in acetylation, the endogenous substrate involved is acetic acid. Examples of drugs that undergoes acetylation include sulfonamide, dapsone, isoniazid, hydralazine, procainamide, clonazepam, para-aminosalicylic acid. The clinical significance of acetylation is that genetic variant existence of slow and rapid acetylators. It will increase the potential for toxicity in slow acetylators and a greater risk of systemic lupus erythematosus, that is SLE, in case of drugs such as hydralazine and procainamide. Then compounds having amino or hydrazine residues are conjugated with the help of acetyl-Coenzyme. Then the next phase 2 reaction is sulfate conjugation. The phenolic compounds and steroids are sulfated by sulfotransferases. Examples include chloramphenicol, methyl dopa, adrenal and sex steroids. Sulfation is less common than glucuronidation. Sulfotransferase is the enzyme that uses the cofactor 3-phosphoadenosine 5-phosphosulfate to add a sulfate to hydroxyl groups, arylamines and N-hydroxyl compounds. The sulfate conjugate is ionized and highly polar to dramatically increase water solubility and excretion of the xenobiotic. Okay, so the fourth one is glutathione conjugation. It results from the addition of a glutathione molecule. Glutathione molecule, it is a tripeptide including glycine, cysteine and glutamic acid to an electrophilic substrate. This glutathione conjugation generally acts to detoxify electrophiles. Glutathione transferase is the enzyme responsible for the reaction. It serves to inactivate highly reactive quinone or epoxide intermediates formed during metabolism of certain drugs, for example, paracetamol. When large amounts of such intermediates are formed, intermediates in the sense toxic intermediates are formed in case of poisoning or after enzyme induction, glutathione supply falls shortly. So the toxic adducts are formed with the tissue constituents that will cause tissue damage. After glutathione is conjugated to the electrophile, the tripeptide is further processed by amide hydrolysis and N-acetyl transferase to the mercaptopuric acid metabolite. So this mercaptopuric acid metabolite is the common metabolite excreted in the urine after glutathione conjugation. The next phase 2 reaction is glycine conjugation. The amino acid conjugation reaction adds either a glycine or a glutamine to a carboxylic acid of the parent drug to form an amide. Coenzyme A forms an intermediate with the carboxylic acid of the parent drug called the acyl coenzyme A intermediate. N-acyl transferase then catalyzes the reaction of the activated xenobiotic, which is the acyl coenzyme A, with the amino acid to form the amide containing metabolite. Salicylates and other drugs having carboxylic acid group are conjugated with the glycine, but this is not a major pathway of metabolism. So the next one is methylation. The amines and phenols can be methylated, methionine and cysteine acting as methyl donors. For example, adrenaline, histamine, nicotinic acid, methyl dopa, captopril, mercaptopurine. This methylation depends on the cofactor S-adenosyl methionine and the enzyme methyl transferase to add a methyl group to oxygen, nitrogen or sulfur containing functional groups. The result of this reaction is generally less polar molecules that can inactivate compounds like the catechol containing neurotransmitters including norepinephrine. More commonly, methylation is responsible for biosynthesis of endogenous compounds like epinephrine through the N-methylation of norepinephrine. Here you can see the examples for common phase 2 reactions. So the first one is glucuronidation. The enzyme involved is UDP glucuronyl transferase and the cofactor is UDP glucuronic acid. Next one is sulfation. The enzyme involved is sulfotransferase and the cofactor is 3-phosphoadenosine 5-phosphosulfate, that is PAPS. Next one is amino acid conjugation. The enzyme involved is N-acyl transferase and the cofactor is glycine and or glutamine. Next one is glutathione conjugation. The enzyme involved is glutathione S transferase and the cofactor is glutathione. Next phase 2 reaction is methylation. The enzyme involved is methyl transferase and the cofactor is S-adenosyl methionine. Next reaction is acetylation. The enzyme involved is N-acetyl transferase and the cofactor is acetyl coenzyme A. So far we have discussed about the classification of biotransformation, which includes the phase 1 and phase 2 reactions. Now we are going to discuss about the extrahepatic metabolism. Okay, so it is nothing but the drug biotransformation outside the liver. Sites with significant metabolic capacity are located at the portals of the entry. For example, gastrointestinal mucosa, nasal passages, lungs, and the portals of excretion, for example, kidneys. But other tissues also contain various drug metabolizing enzymes. So the first one is the intestinal mucosa. It is a significant site of metabolism for drugs that are administered orally and contributes to the observed first pass effect or pre-systemic metabolism. Next one is the nasal mucosa. Like the gastrointestinal mucosa, it is considered a portal of entry and contains a high level of cytochrome P450 activity as well as some FMO. FMO means flavin containing monooxygenase, then esterase and conjugation activity. Many compounds administered nasally also undergo significant nasal metabolism to decrease the systemic effects. For examples, topical decongestants, anesthetics, nicotine, and cocaine. So the next extrahepatic site is the intestinal flora. It is responsible for producing many reductase and glucuronidase enzymes. So the first one is reductases, including nitroreductase and azoreductase, reduce aromatic nitro and azo functional groups into amines. One example of an azoreductase activity is the reduction of the azo bond in sulfasalazine to release the anti-inflammatory aminosalicylic acid and the antibacterial sulfapyridine. Next one is the glucuronidase enzyme. These enzymes are responsible for the hydrolysis of the polar glucuronide conjugates in the bile to release the free deglucuronidated drug, which is free for reabsorption. We have seen this in the glucuronide conjugation. So in glucuronide conjugation, the glucuronic acid, which is of large size, which conjugate with the drug. Okay, so the drug glucuronide conjugate, the complex will be of large size. Okay, so because of its large size, this complex cannot enter into the blood. So it will enter into the bile and excreted in feces. 10%. Okay, so remaining there will be 90%. So this 90% will be hydrolyzed by the bacteria in the gut. Okay, so this hydrolysis is catalyzed or performed by this glucuronidase enzymes in the intestinal flora. Okay, so because of this hydrolysis, the 90% of the drug gets split into drug and the glucuronic acid, and the process repeats. And this to and fro motion from liver to intestine and intestine to liver is known as the enterohepatic cycling. Okay, so this process of glucuronide conjugates secretion into the GI tract with the bile being hydrolyzed by glucuronidases and then being reabsorbed is called enterohepatic circulation. Estrogen is an example of a drug that demonstrates enterohepatic circulation. Changes in the number or population of intestinal flora can influence the activity of a drug. Conditions such as diarrhea, intestinal diseases, or antibiotic treatment all alter the intestinal flora and therefore may result in changes in drug activity. Okay, so the fourth one is the lungs. The lungs express many cytochrome P450s, FMO, that is flavin containing monooxygenase, epoxide hydrolase and conjugation pathways, and therefore contribute to the metabolism of many xenobiotics that either enter the body through the lungs or via the circulation. The lungs are the site of first pass metabolism for drugs administered intravenously, intramuscularly, transdermally or subcutaneously, and the site of second pass metabolism for xenobiotics that leave the liver. Next one is plasma. Plasma contains esterases that hydrolyze esters to either inactive ester containing drugs, for example procaine and succinylcholine, or activate ester prodrugs, for example enalapril. Next one is the placenta. Placenta has very limited drug metabolizing capacity. Drugs that are easily absorbed are usually capable of crossing the placenta. Placentas of mothers that smoke tobacco have a significant increase in the expression of the CYP1A subfamily. This is of concern because it may result in increased exposure of the fetus to reactive metabolites that may have detrimental effects. Next one is the fetal metabolism. It is dependent on the age of the fetus. Cytochrome P450 activity is present early in the gestation, but glucuronidation is deficient until after birth. This lack of glucuronidation results in grey baby syndrome after chloramphenicol administration and neonatal hyperbilirubinemia. Next is the kidney. Kidney expresses cytochrome P450s that are mostly involved in the hydroxylation of steroids, arachidonic acid and 25-hydroxycholecalciferol. The next one is the non-enzymatic degradation of drugs. It can occur in the body, but the acidic environment of the stomach can cause the degradation of a number of drug molecules, for example penicillin G, erythromycin, tetracycline and peptides like insulin. Moving on to the mechanism of metabolism, only a few drugs are metabolized by enzymes of intermediary metabolism. For example, alcohol by dehydrogenase, allopurinol by xanthine oxidase, succinylcholine and procaine by plasma cholinesterase, adrenaline by monoamine oxidase. So majority of drugs are acted on by relatively non-specific enzymes which are directed to types of molecules rather than to specific drugs. The same enzyme can metabolize many drugs. So the drug metabolizing enzymes are divided into two types. The first one is microsomal enzymes and the next one is non-microsomal enzymes. Okay, so the drug metabolizing enzymes are divided into two types. They are microsomal enzymes and non-microsomal enzymes. So the first one is microsomal enzymes. These are located on smooth endoplasmic reticulum, primary in the liver, also in kidney, intestinal mucosa and lungs. The monooxygenases, cytochrome P450, glucuronidal transferase, etc. are microsomal enzymes. They catalyze most of the oxidations, reductions, hydrolysis and glucuronide conjugation. Microsomal enzymes are inducible by drugs, diet and other agencies. Next one is non-microsomal enzymes. They are present in the cytoplasm and mitochondria of hepatic cells as well as in other tissues including plasma. The flavoprotein oxidases, esterases, amidases and conjugases are non-microsomal. Reactions catalyzed are some oxidations and reductions, many hydrolytic reactions and all conjugations except glucuronidation. The non-microsomal enzymes are not inducible but may show genetic polymorphism. For example, acetyl transferase, pseudocholine esterase. So we have already said that the drug metabolizing enzymes are divided into two types, that is microsomal and non-microsomal enzymes. These microsomal enzymes are present in the endoplasmic reticulum of the hepatocytes, whereas these non-microsomal enzymes are present in the cytoplasm or mitochondria of the hepatocytes, and these microsomal enzymes catalyze most of the oxidation, reduction, hydrolysis and glucuronide conjugation. These microsomal enzymes are inducible. Okay, so they can be induced and inhibited by drugs. So it can lead to a lot of drug-drug interactions. And the non-microsomal enzymes are not inducible. Okay, they are not inducible and are not inhibited, but may show genetic polymorphism. Okay, but may show genetic polymorphism. Both microsomal and non-microsomal enzymes are deficient in the newborn, especially premature, making them more susceptible to many drugs. For example, chloramphenicol opioids. This deficit is made up in the first few months, more quickly in case of oxidation and other phase 1 reactions than in case of glucuronide and other conjugations taking 3 or more months. The third mechanism of metabolism is known as Hoffmann elimination. The peculiarity of this Hoffmann elimination is that no enzyme is required. This refers to inactivation of the drug in the body fluids by spontaneous molecular rearrangement without the agency of any enzyme. An example for this Hoffmann elimination is atracurium. So here we are going to learn about two important concepts, that is enzyme induction as well as enzyme inhibition. So starting with inhibition of drug metabolism. So one drug can competitively inhibit the metabolism of another if it utilizes the same enzyme or cofactors. A drug may inhibit one isoenzyme while being itself a substrate of another isoenzyme. This can be explained with the help of an example. For example, quinidine is metabolized by CYP3A4, but it inhibits the isoenzyme CYP2D6. Also, most drugs at therapeutic concentrations are metabolized by non-saturation kinetics. Non-saturation kinetics means the enzyme is present in excess amount. Okay, so it will not get saturated. Clinically significant inhibition of drug metabolism occurs in case of drugs having affinity for the same isoenzyme, especially if they are metabolized by saturation kinetics or if kinetics changes from first order to zero order over the therapeutic range, which means capacity limited metabolism. Obviously, inhibition of drug metabolism occurs in a dose related manner and can precipitate toxicity of the object drug, which means whose metabolism has been inhibited. The more important cytochrome P450 inhibitors are erythromycin, ketoconazole and ritonavir because they each inhibit several cytochrome isoenzymes. So in a nutshell, we can say that what is happening in this enzyme inhibition? Enzyme inhibitors prevent the cytochrome P450 enzymes from working or reducing the rate of an enzyme catalase reaction. So ultimately what will happen? This decreases the metabolism of the drug. Okay, this decreases the drug metabolism in the body and increases the potential for toxicity. So the effect often occurs quickly and is dose related. Okay, so enzyme inhibition will lead to toxicity of the parent drug. Because enzyme inhibition occurs by direct effect on the enzyme, it has a fast time course, means it occurs within hours compared to enzyme induction. Okay, so comparing to enzyme induction, this enzyme inhibition has got a fast time course. That is, enzyme inhibition will occur within hours compared to enzyme induction. Now, the metabolism of drugs with high hepatic extraction is dependent on liver blood flow. Liver blood flow means blood flow limited metabolism. So for example is propranolol. We know that propranolol is a non-selective beta blocker. This propranolol reduces the rate of lidocaine metabolism by decreasing hepatic blood flow. Some other drugs whose rate of metabolism is limited by hepatic blood flow are morphine, propranolol, verapamil, and imipramine. Next is microsomal enzyme induction. The cytochrome P450 dependent enzymes are an important target for pharmacokinetic drug interactions. Many drugs, insecticides and carcinogens interact with the DNA and increase the synthesis of microsomal enzyme protein, especially cytochrome P450 and glucuronidase transferase. As a result, rate of metabolism of inducing drug itself and or other drugs is increased. Okay, certain drugs, for example, that is examples for enzyme inducers include phenobarbital, rifampin, phenytoin, carbamazepine, and oral contraceptives. They are all capable of inducing cytochrome P450 isoenzymes. So this results in increased biotransformation of the drugs and can lead to significant decrease in plasma concentrations of the drugs metabolized by these cytochrome isoenzymes, often with concurrent loss of pharmacological effect. Okay, so in a nutshell, we can say that what will happen in this enzyme induction, this will increase the metabolism of the parent drug. Okay, so the particular parent drug will be increasingly metabolized and thereby its concentration will decrease in the plasma so that the drug cannot produce its action. Okay, so it will lead to therapeutic failure or treatment failure. Then induction involves microsomal enzymes in liver as well as other organs and increases the rate of metabolism by 2 to 4 fold. Induction takes 4 to 14 days to reach its peak and is maintained till the inducing agent is being given. Thereafter, the enzymes return to their original value over 1 to 3 weeks. So enzyme inducers, what they will do? They will increase the expression level of cytochrome P450 enzymes, resulting in increased metabolism of the drugs. Okay, and thereby subsequently reducing the therapeutic concentration. Therefore, potential changes in drug concentration may cause treatment failure. The effects usually develop over several days and may be slow to resolve depending upon the half-life of the inducer. So the enzyme inhibition will lead to toxicity of the parent drug, whereas enzyme induction will lead to decreased efficacy of the parent drug, or it will lead to treatment failure or therapeutic failure. Examples for enzyme inducers include phenobarbital, rifampin, phenytoin, carbamazepine, etc. So examples for enzyme inducers include anticonvulsants such as phenytoin, carbamazepine, phenobarbital, then steroids including dexamethasone, prednisolone, then antibiotics such as rifampicin, griseofulvin, then other agents including nicotine, cigarette smoke, St. John's wort. The St. John's wort is also known as Hypericum perforatum. Okay, it is a herbal medicine. Then enzyme inhibitors examples include azoles, which includes ketoconazole and fluconazole. Then antibiotics including sulfonamides, metronidazole, ciprofloxacin, chloramphenicol macrolides and isoniazid. Then cimetidine, omeprazole, sodium valproate, grapefruit, ritonavir. Now let's see the consequences of microsomal enzyme induction. So the first one is microsomal enzyme induction will lead to decreased intensity and duration of action of drugs that are inactivated by metabolism. For example, failure of contraception with oral contraceptives. As we have already learned that this microsomal enzyme induction will lead to decreased efficacy or therapeutic failure of the substrate or the parent drug. Suppose if we are taking an enzyme inducer with an oral contraceptive, it will lead to oral contraceptive failure. Next point is tolerance. Tolerance means if the drug induces its own metabolism. Okay, so this condition is known as auto-induction. Okay, so the tolerance can occur to drugs that have the auto-induction potential. For example, carbamazepine, then rifampin. Next point is some endogenous substrates such as steroids, bilirubin are also metabolized faster. Then precipitation of acute intermittent porphyria. So this enzyme induction increases porphyrin synthesis by depressing aminolevulinic acid synthetase. Then intermittent use of an inducer may interfere with adjustment of dose of another drug prescribed on a regular basis. For example, oral anticoagulants, oral hypoglycemics, antiepileptics, antihypertensives. Suppose if the patient is on a long-term stay in a hospital. Okay, so he might be taking oral contraceptives or oral hypoglycemics or antiepileptics. Okay, so like that kind of drugs. If the patient require an enzyme inducer, okay, so the adjustment of dose is required. Okay, so this is the point. Adjustment of dose is required if the patient is on a long-term therapy or if the patient is on chronic drugs such as oral anticoagulants, oral hypoglycemics, antiepileptics. If such patients are prescribed with an enzyme inducer, dose adjustment should be done. Then drugs whose metabolism is significantly affected by enzyme induction are phenytoin, warfarin, tolbutamide, imipramine, oral contraceptives, chloramphenicol, doxycycline, theophylline, griseofulvin, and phenylbutazone. Okay, so the next important concept is first pass metabolism, or also known as pre-systemic metabolism. This refers to metabolism of a drug during its passage from the site of absorption into the systemic circulation. Or otherwise we can say that the drug has to pass the liver first before going into the systemic circulation. All orally administered drugs are exposed to drug metabolizing enzymes in the intestinal wall and liver, where they first reach through the portal vein. The portal vein carry the drug into the liver, where the metabolism occurs, and from the liver the hepatic vein carry the metabolized drug into the systemic circulation. Pre-systemic metabolism of limited magnitude can also occur in the skin in case of transdermally administered drugs, and in lungs for drug reaching venous blood through any route. The extent of first pass metabolism differs for different drugs, and it is an important determinant of oral bioavailability. Suppose if a drug has got high first pass metabolism, means that drug will not be effective by the oral route. And here you can see the attributes or features of drugs with a high first pass metabolism. So the first one is oral dose is considerably higher than the sublingual or parenteral dose. Next point is there is marked individual variation in the oral dose due to differences in the extent of first pass metabolism. The third point is oral bioavailability is apparently increased in patients with severe liver disease. And the fourth one is oral bioavailability of a drug is increased if another drug competing with it in first pass metabolism is given concurrently. For example, chlorpromazine and propranolol. Factors that influence drug metabolism. So the first factor is the chemical structure of a xenobiotic, or the chemical structure of a drug. It has one of the largest influences on the metabolism of the compound. The presence or absence of certain functional groups will determine the necessity, route, and extent of metabolism. Next factor is genetic difference or polymorphism. Okay, so this factor can influence the activity or the extent of expression of the drug metabolizing enzymes. For example, the rate of acetylation is one example that depends on the amount of N-acetyltransferase that is expressed. Individuals can be divided into fast or slow acetylators based on the expression of N-acetyltransferase. CYP2D6 is a highly polymorphic enzyme that results in the division of individuals into ultra-rapid, intermediate, or poor metabolizers of substrates like debrisoquine and dextromethorphan. Next factor is gender. Metabolic differences between the genders have been observed for a number of compounds, suggesting that androgen, estrogen, and or adrenocorticoid activity might affect the activity of certain cytochrome P450 isoenzymes. For example, metabolism of diazepam, prednisolone, caffeine, and acetaminophen is slightly faster in women. Then metabolism of propranolol. The common brand name for this propranolol is Inderal, and chlordiazepoxide brand name is Librium. Lidocaine brand name is Xylocaine. And some steroids is faster in men than in women. Next factor is age. So the first point is the fetus and the neonate do not have fully developed drug metabolizing enzymes, particularly phase 2 glucuronidation. As a result, smaller doses are often required to avoid drug accumulation and adverse effects during the first 6 to 8 weeks of life. Next point is the elderly patient shows a decrease in the drug metabolizing capacity compared to young adults. This may be due to changes in the hepatic blood flow, body mass, and or other disease states. Drug clearance is therefore generally slower and blood concentrations are higher, increasing the potential for toxicity. This is how the age can affect the metabolism of various drugs. Next factor is circadian rhythms. The nocturnal plasma levels of drugs such as theophylline and diazepam are lower than the diurnal plasma levels. Okay, for certain drugs such as theophylline and diazepam, circadian rhythm may affect the metabolism of such drugs. Next factor is various disease states that influence the function of the liver. Okay, we know that liver is the major site of drug metabolism. It can affect the drug's hepatic clearance. So alterations in the liver blood flow, loss of functional hepatocytes, and changes in the albumin production can influence the extent of drug metabolism and toxicity, and therefore require caution when administering a drug that requires hepatic biotransformation for detoxification or elimination. Next factor is the nutritional status of an individual. This nutritional status can also influence the activity of drug metabolizing enzymes by altering the amount of conjugating agents, protein, essential fatty acids, minerals, and or vitamins available for use. Another factor that affecting the drug metabolism is interacting substances. Okay, the xenobiotics, whether they are drugs or not, can influence the activity of drug metabolizing enzymes in a variety of ways. So the first one is inducers. Okay, inducers. We have already discussed. Inducers are xenobiotics that cause an increase in the drug metabolizing activity of a target enzyme, usually by increasing the concentration of enzyme in the liver or by other tissue. So in case of drug-drug interactions, the compound causing the induction is called the precipitant drug, whereas a drug that is being affected is called the object drug. Okay, so the compound causing the induction, the compound responsible for causing the induction is called the precipitant drug, whereas the drug that is being affected is called the object drug. The consequences of induction is dependent on the extent of induction by the precipitant drug and the pharmacological characteristics of the object drug. Next point is enzyme inhibitors. Okay, enzyme inhibitors are opposite of inducers in that they decrease the metabolizing activity of target enzyme, usually by competing with the object drug for the enzyme and or preventing its metabolism. The extent of inhibition is dependent on the affinity of the inhibitor, the availability of alternate metabolic pathways of the object and the pharmacological characteristics of the object drug. Next point is the extent of protein binding. The extent of protein binding can be altered by the administration of another compound that is also highly protein bound. Okay, so the two drugs that compete for similar binding sites on the plasma proteins can result in the displacement of the agent with the lower affinity. We have seen this in the distribution. These are certain kinds of displacement interactions. Okay, so the one having the higher affinity will bind to the plasma protein. Okay, compared to the one having the lower affinity. So as a result, there is an increase in the free fraction of one or both drugs that can lead to increased receptor interactions, metabolism or toxicity of the displaced drug. Next point is antibiotic therapy. Antibiotic therapy may also influence the metabolic rate of a drug that is dependent on the gut microflora for its metabolism or enterohepatic circulation. Next factor is route of administration. The route of administration can dramatically influence the metabolic rate of a drug. So first see about the orally administered drugs. So this orally administered drugs are subject to first pass metabolism in the liver through the portal circulation or pre-systemic metabolism in the gut. This first pass or pre-systemic metabolism can significantly reduce the amount of drug that enters the systemic circulation. Often, this problem can be overcome by administering more drug orally so that the systemic concentration is sufficient for pharmacological activity. Next route of administration is intravenous route. Okay, so the feature of this intravenous route of administration is that it bypasses any barriers to GI absorption and first pass metabolism and generally requires a smaller dose for the same effect. Here the drug is directly entering into the systemic circulation. Okay, so the feature is that it bypasses first pass metabolism. For example, oral morphine undergoes significant first pass metabolism, so an equivalent IV dose is approximately 1/6 that of an oral dose. Sublingual and buccal administration also bypass the first pass metabolism because they are not part of the portal circulation. Next is the rectal administration. Rectal administration is more variable but also bypasses first pass metabolism to a significant extent. Okay, so the last factor is the dose. The dose can also influence the extent of metabolism. There is a finite amount of drug metabolizing enzymes, so higher doses can result in saturation of a particular metabolic pathway. So when this occurs or when this saturation occurs, what will happen? An alternate pathway may contribute to the metabolism of the drug. For example, acetaminophen given at therapeutic doses is metabolized almost exclusively by glucuronidation and sulfation, but toxic doses saturate these processes. Okay, that will lead to increased metabolism by CYP2E1 isoenzyme to the proposed toxic metabolite NAPQI, that is N-acetyl parabenzoquinoneimine, which is responsible for causing hepatotoxicity. This is how dose can influence the extent of metabolism. Prodrugs. Prodrugs means these are drug molecules that are either inactive or very weakly active and require in vivo biotransformation to produce a pharmacologically active drug. So prodrugs means as such they are inactive. After metabolism, they will get converted to pharmacologically active drug. Now what all are the advantages of a prodrug instead of the active form of a drug? First one is an increase in water solubility. It is useful for the preparation of ophthalmic and parenteral formulations. Sodium succinate esters and sodium phosphate esters have been used to make a number of water-soluble steroid products. Next advantage is an increase in lipid solubility. So the first one is increased oral absorption. It is obtained by converting carboxylic acid groups to esters. These esters that can then be rapidly converted to the active acids by plasma esterases. An example is enalaprilat. Enalaprilat is a potent angiotensin converting enzyme inhibitor that is used for parenteral administration. But due to its high polarity, it is orally inactive. Its monoethyl ester enalapril is considerably more lipophilic and thus provides good oral absorption. So this enalapril is a prodrug. Okay, it has got good oral absorption and the active metabolite of this enalapril is enalaprilat. Okay, enalaprilat it is not orally active. Okay, so it is mainly given through the parenteral route. Okay, so this enalapril is a prodrug and its active metabolite is enalaprilat. Next is increased duration of action. Lipid soluble esters of estradiol such as benzoate, valerate and cypionate are used to prolong estrogenic activity. Intramuscular injections of these esters in oil result in a deposit of drug that is slowly released and hydrolyzed to free estradiol over a prolonged period. Third point is increased topical absorption of steroids. It is obtained by masking hydroxyl groups with a less polar functional group such as esters or acetonides. This decrease in polarity allows for increased dermal permeability to treat inflammatory, allergic and pruritic skin conditions. Examples include triamcinolone acetonide and beta-methazone valerate. The fourth point is increased palatability. Antibiotics such as sulfasoxazole have a bitter taste and are not suitable for administration to children who are unable to swallow tablets or capsules. So the esterification to produce sulfasoxazole acetate decreases the water solubility of the antibiotic and thus decreases its interaction with bitter taste receptors on the tongue. This compound is marketed as a flavored suspension with a erythromycin ethyl succinate. Okay, so this esterification is responsible for increasing the palatability, that is improving the taste. Similar strategies have been used to mask the bitter taste of chloramphenicol and other antibiotics. Next advantage is a decrease in gastrointestinal irritation. NSAIDs produce gastric irritation and ulceration via two mechanisms. First one is a direct irritant effect of the acidic molecule and next one is the inhibition of gastroprotective prostaglandin production. The prodrugs sulindac and nabumetone produce less gastrointestinal irritation because the gastric and intestinal mucosa are not exposed to high concentrations of active drug during oral administration. Additionally, nabumetone is a ketone, it is not an acid and lacks any direct irritant effects. Next advantage is site specificity. Site specificity is useful for increasing the concentration of the drug at the active site and for decreasing the side effects. So let's discuss some examples. First one is methyl dopa. Methyl dopa is a central sympatholytic drug. Also, it is a prodrug that is structurally similar to levodopa. As a result, methyl dopa is transported into the central nervous system and metabolized to the active compound alpha methyl norepinephrine via the same path used for the synthesis of norepinephrine. This allows a significant amount of alpha methyl norepinephrine to activate central alpha 2 adrenergic receptors. So this methyl dopa is a prodrug. Its active metabolite is alpha methyl norepinephrine. Next example is omeprazole. Omeprazole is used to treat gastric ulcers and other hypersecretory disorders. After oral absorption, it is selectively activated at the acidic pH levels, that is pH less than 1, seen in the gastric parietal cells. This allows the active form of the drug to be produced in proximity to the enzyme H plus K plus ATPase, which is known as the proton pump, resulting in irreversible inhibition of the enzyme and a decrease in gastric acid secretion. Activation in the stomach prior to absorption can be prevented by the use of enteric coated formulations. Next example for the site specificity is formaldehyde. Formaldehyde is an effective urinary tract antiseptic. However, oral administration results in significant toxicity. Okay, so in order to avoid this problem, the prodrug methenamine is administered instead. Okay, so the prodrug of this formaldehyde is methenamine. Methenamine is stable and non-toxic at normal physiological pH but is selectively hydrolyzed to formaldehyde and ammonium ions in the acidic urine. Acidic urine means pH less than 5.5. So as with omeprazole, activation before absorption can be prevented by the use of enteric coated formulations. Okay, so this methenamine is a prodrug. Okay, methenamine after hydrolysis, it will get converted to formaldehyde and ammonium ions in the acidic urine. Next example is olsalacin. This olsalacin is a highly polar dimer of 5-amino salicylic acid that is poorly absorbed after oral administration. On reaching the large intestine, colonic bacteria cleave the azo bond and liberate the active anti-inflammatory agent. All psilocin and a related compound, that is sulfasalazine, are useful in treating inflammatory bowel disease. Next advantage is increased shelf life. Increased shelf life of both solids and parenteral admixtures can be obtained by the use of prodrugs. For example, we know that cyclophosphamide, which is an anti-cancer agent, it is a prodrug that requires in vivo oxidation followed by non-enzymatic decomposition to produce the active phosphoramide mustard. As a result, aqueous solutions of cyclophosphamide are much more stable than those of other nitrogen mustards. Next, we will learn about the strategies to manage the drug metabolism. There are mainly three strategies which include pharmaceutical strategies, pharmacological strategies and chemical strategies. We will discuss each strategies in detail. So the first one is pharmaceutical strategies. Among these pharmaceutical strategies, the first strategy is sublingual tablets. Okay, so the sublingual tablets are useful for delivering drugs directly into the systemic circulation and avoiding hepatic first pass metabolism. An appropriate example is nitroglycerin. It is a rapidly acting anti-anginal agent. It is essentially ineffective when administered orally due to an extremely high first pass effect, but is very effective in treating acute attacks of angina if given sublingually. Next strategy is transdermal patches and ointment formulations. These formulations provide a continuous supply of drug over an extended period and are useful for rapidly metabolized compounds such as nitroglycerin. Next point is intramuscular depot injections. This IM or intramuscular depot injections also provide a continuous supply of drug over an extended period. Highly lipid soluble esters of estradiol and testosterone, for example estradiol benzoate, testosterone enanthate, are slowly absorbed from their administration site. Hydrolysis of these prodrugs produces a steady supply of these rapidly metabolized hormones. Next pharmaceutical strategy is enteric coated formulations. Okay, so these enteric coated formulations can protect acid sensitive drugs as they pass through the acidic environment of the stomach. Methenamine, erythromycin and omeprazole are examples of acid sensitive agents that are available as enteric coated preparations. Next strategy is nasal administration. It allows for the delivery of peptides such as calcitonin in salmon, which have very low oral bioavailability. Characteristics of the mucosa make it ideal for the administration of peptides. Aerosolized drugs only need to penetrate a thin epithelial layer to reach abundant capillary beds. Next one is inhalation. Inhalation as a route of administration is most commonly used for local activity but can bypass gastric or hepatic metabolism for systemic administration. Inhaled insulin is effective but was removed from the market because of adverse effects on the lungs. Coming to the pharmacological strategies, it involved the concurrent use of enzyme inhibitors to decrease drug metabolism. In some instances or in some cases, the concurrent use of an additional agent does not prevent metabolism but rather prevents the toxicity caused by metabolites of the therapeutic agent. So the pharmacological strategies include or the pharmacological strategies aim to prevent the metabolism or toxicity caused by the metabolites of the therapeutic agent by the use of an additional agent. So let's see some examples. So the first one is levodopa. It is the amino acid precursor of dopamine. It is used in the treatment of Parkinsonism. Unlike dopamine, levodopa can penetrate the blood-brain barrier and reach the CNS. Dopamine or the dopa cannot penetrate the blood-brain barrier, but levodopa can penetrate the blood-brain barrier and reach the CNS. So once in the brain, it is decarboxylated to dopamine. To ensure that adequate concentrations of levodopa reach the CNS, peripheral metabolism of the drug must be blocked. Okay, so the concurrent administration of carbidopa. What is carbidopa? Carbidopa is a peripheral decarboxylase inhibitor or a dopa decarboxylase inhibitor that cannot penetrate the blood-brain barrier, prevents the peripheral conversion of levodopa to catecholamines and allows enhanced delivery of levodopa to the CNS. Next example is beta-lactam antibiotics. The antibacterial activity of a number of beta-lactam antibiotics is reduced by microorganisms capable of secreting the enzyme beta-lactamase. This enzyme hydrolyzes the beta-lactam ring and inactivates the antibiotic. So to counter this resistance mechanism, a beta-lactamase inhibitor such as clavulanic acid sulbactam is used in conjunction with a penicillin such as amoxicillin to successfully treat infections caused by beta-lactamase producing bacterium. Next pharmacological strategy is the case of ifosfamide. It is an alkylating agent that must undergo in vivo metabolism to produce an active nitrogen mustard. In the process of this metabolic activation, a significant concentrations of acrolein are produced. These acrolein molecules react with nucleophiles on renal proteins and produce hemorrhagic cystitis. Okay, so this acrolein is responsible for producing hemorrhagic cystitis, which is one of the major toxicity associated with the cyclophosphamide and ifosfamide. To prevent this toxicity, ifosfamide is always co-administered with mesna. Mesna is a sulfhydryl containing compound that reacts with and neutralizes any acrolein that is present in the kidney. Next pharmacological strategies, HIV protease inhibitors. These HIV protease inhibitors are extensively metabolized by CYP3A isoenzymes, but they also inhibit these same isoenzymes in the process. This latter action has been used to optimize therapy. For example, ritonavir is an HIV protease inhibitor with very high affinity for CYP3A isoenzymes, whereas lopinavir is rapidly oxidized and inactivated by the same enzyme. So, a combination of low-dose ritonavir with a therapeutic dose of lopinavir results in an inhibition of CYP3A, the establishment of adequate plasma levels of lopinavir, and therapeutic efficacy without hepatotoxicity. Okay, so the third strategy is chemical strategies. Okay, so the chemical strategies involve the addition, deletion, or isosteric modification of key functional groups. These molecular modifications hinder or completely eliminate metabolic transformations. Let's see some examples. So the first one is testosterone. Testosterone is not orally active due to rapid oxidation of its 17-hydroxyl group to a ketone. So addition of a 17-methyl group converts the labile secondary alcohol to a stable tertiary alcohol. The resulting compound methyl testosterone is only half as potent as testosterone. However, it is not subject to rapid first-pass metabolism and can be used orally. A similar strategy has been used to make orally active estradiol analogs. Next example is tolbutamide. It is an oral hypoglycemic with short duration of action. This sulfonylurea rapidly undergoes oxidation of its para-methyl group. A structurally similar compound, chlorpropamide, has a non-metabolizable para-chloro group, and as a result, it has much longer duration of action compared to tolbutamide. Next example is the case of isoproterenol. It is a potent adrenergic agonist used for the relief of bronchospasm associated with the bronchial asthma. Because it is a catechol, that is 3,4-dihydroxy substituted benzene ring, isoproterenol is subject to rapid metabolism by COMT. COMT means catechol orthomethyl transferase, and thus has poor oral activity. So alteration of the 3,4-dihydroxy substitution to a 3,5-dihydroxy substitution produces metaproterenol, a bronchodilator that is not susceptible to COMT. COMT means catechol orthomethyl transferase. It is orally active and has a longer duration of action than isoproterenol. Next example is the case of octreotide. It is a synthetic octapeptide used to suppress or inhibit severe diarrhea associated with certain tumors. Octreotide mimics the actions of somatostatin, which is a naturally occurring 14 amino acid peptide. Somatostatin undergoes rapid proteolysis, has a half-life of 1 to 3 minutes, and must be administered as a continuous intravenous infusion. Octreotide contains the amino acids essential for clinical efficacy, but replaces 2 of the amino acids with their dextro enantiomers. These unnatural dextro amino acids are more resistant to hydrolysis. As a result, octreotide has an increased half-life and can be administered as a subcutaneous injection. So we have completed the metabolism part of pharmacokinetics. So far we have discussed about what is metabolism and what are the different types of metabolism, that is phase 1 and phase 2 reactions, then first pass metabolism, then enzyme inhibition and enzyme induction, the concept of prodrugs, then strategies to manage drug metabolism and the factors affecting drug metabolism. If you require further information or further details, you can refer Comprehensive Pharmacy Review for NAPLEX and Lipincow textbook for Pharmacology. So thank you for watching this video. Have a great day.